far as that we've had regional confidential inquiries into asthma deaths stretching back right through to the mid-1980s, actually. And it'll not surprise you to know that the one that I've pulled out to present is the most recent of the number that's been done regionally, which was back, well, no, actually, it's the furthest away one, back in 1989-90, and it came from the Mersey region. There's been one in Scotland, there's one in the east of England and East Anglia, where a lot of you are currently sitting. All of them pretty much come up with the same thing. And what they did in each of these regional inquiries was to try and pull out every death from asthma in their area, and then get an expert panel to both interview the physicians and also interview the patient relatives of people who died of asthma. And sadly, the conclusions that they came to are ones that suggested that in a large number of people back in the 1980s and 1990s, the asthma death could have been prevented, either if the patient had acted differently and more rapidly, or if the clinicians had acted differently and more rapidly. And as we go through the stuff that we've got from the 2014 version, I'm sure that, like me, you will end up with sadly, an overwhelming feeling of deja vu. So next slide, please. Thank you. So this one here comes from the Eastern Region Confidential Inquiry back in 2006. And basically, the recommendations of the publishers of that, which is published in the PCRJ at that time, were almost identical to the recommendations coming out from the National Review of 2014, which is clearly almost a decade later. Okay, next slide. And the information that's come out of the confidential inquiries, the regional ones, has informed the signed BTS guidelines. It's been accepted by them as a form of evidence that they would accept. It's also informed north of the border healthcare improvement standards and south of the border NICE standards in asthma. And it's also informed a whole bunch of other stuff, including RCGP curriculum, etc. Next slide, thank you. And this is a guy that some of you may recognise. This guy is a guy called Mark Levy, who's a GP in Harrow. Well, he's retired now. He was a GP in Harrow for the best part of 30 years. And Mark was a founder member of what was in those days the GPIAG, which is now the Primary Care Respiratory Society. And he was the guy who was commissioned to be the lead investigator and author in the first ever, and possibly the last ever, to be honest with you, National Review of Asthma Deaths. And so everything that was done in this was done with Mark's level of diligence and conscientiousness, which, for those of us who know him, know that it's legendary. This guy's level of interest in detail is second to none. And I think that's worth emphasising when it comes to discussing the findings of the review. He's also a man who very much wants to sort the acute management of asthma, and he's had a career-long dedication to sorting the acute management of asthma, and that comes out loud and clear as we go through what's in this inquiry as well. Next slide, please. So from here on, we'll call it NRAD, the National Review of Asthma Death, and it was funded by both NHS England and the Scottish Government, and there was also money came in from the executive in Wales and Northern Ireland. And what happened was that it was a multidisciplinary, multi-agency steering group, of which I had the privilege to be part, and I was there with a representing Scotland hat on more than anything else, to be honest with you. And it was run under the auspices of the Royal College of Physicians, but with the cooperation of all other relevant Royal Colleges as well. And what they then did was they commissioned an investigative team of people at the RCP who are experts in doing these kind of inquiries. There are ongoing and standing confidential inquiries into certain things like maternal death, intranatal maternal death, and infant mortality as well. And those things run on a year by year by year basis. And so the methodology that they use was exported into this kind of one-off exercise. Next slide. So the way this thing worked was that the Registrar for Births, Deaths and Marriages was was obliged in a statutory manner to provide death certificate details for every person in whom the word asthma had been put on their death certificate. Now, Asthma UK's figures and other expert bodies' figures would suggest that the number of people who've died from asthma in the UK every year has fallen from about 3,000 in the early 1990s down to about half of that now, somewhere between 1,000 and 1,500. The problem with that is that that's anyone in whom the word asthma has been mentioned on the death certificate. So if, for example, you go into hospital because you've fallen off your motorbike and you've broken your leg and your pelvis and about another 7 bones, but you've also got asthma, and as a consequence of your multiple injuries, you perish, and somebody thinks that it's relevant to write asthma in your death certificate, then that would have been included in the figures for deaths of people who have asthma. And that's a problem, because your asthma may or may not, under those circumstances, be relevant to your death. So if what happened was that when you had a general anaesthetic to get all your bones fixed, you had an acute asthma event, which is entirely possible when somebody with asthma is exposed to anaesthetic gases, then your death would have been relevant to, your asthma would have been relevant to demise. However, if what actually happened was that you bled out at the side of the road and you died of shock because of your multiple trauma injuries, the fact that you had asthma was neither here nor there. And that therefore became extremely difficult to tease out when it came to working out what was going on with these people who had asthma in their death certificates. And actually that was one of the challenges of doing this exercise, because what then happened was that that headline number between 1,000 and 1,500 people per annum who die with a certificate that says asthma actually became distilled down to around about 200 people in whom you could definitely say that you had all the information available and that you were confident that the primary cause of death was asthma. Now, it's important to understand that, and I've taken some time about explaining that, because some of the numbers that have been bandied around in the last years, or 15 months since this was published, would suggest that what's happened is that the death rate from asthma has dropped from its previous 1,500 per annum down to 200 per annum. That's not true. This inquiry only looked at 200 people because that's the only number of people in whom they could be absolutely confident that asthma was the primary cause of death. And we still don't actually really know what the headline number of people that die of asthma is, because the way that we write death certificates just isn't accurate enough. So what then happened with this inquiry was that each of those, there was actually 195 people whose death sadly happened as a direct consequence of asthma. That was then, their details were both in terms of case records and a report from their physician or clinician that was looking after them, and also a report from a confidential and sensitive interview that took place with their families, was then presented to a regional inquiry team of people who were experts in the management of asthma, people from primary and secondary care, from community care, ICU, etc. And the paperwork that they had was standardised. The questionnaires that were sent out to everybody that was involved in the care of that patient was standardised, and there was a standardised reporting structure, which was then subjected to a quality assurance to make sure that each of those regional inquiry teams was coming to roughly similar conclusions if they were presented with roughly similar clinical data. Okay, and then the final conclusions for that were written up by a team headed up by Mark Levy, but including people like Mike Thomas, who many of you may know, who's the professor of primary care down in Southampton. Next slide, please. Well, that's pretty much what I've just said, so you can skip over that one, sorry. So, just to reiterate, what NRAD isn't is a comprehensive review of every death where asthma was a factor. It's not an accurate number of deaths per annum. It was very much designed not to be a witch hunt. These confidential inquiries can only happen if the people who've gone through the clinical experience of this patient becoming ill and dying are open and honest in their reporting. And so there was a kind of guarantee, if you like, this would not become was a witch hunt. Although it has to be said that there was also a codicil that should the investigators at any point come across a situation which they thought ought to be reported to the General Medical Council, then they did that. It's not double-blinded, randomised science, but it's a good methodology, and it's one that I hope that we'll be able to use again. Okay, next slide. The report, for anyone who's read it, is a no-hold-barred report, and we're going to go through some of the headline stuff as we go on in the next few slides. It's by clinicians for clinicians, and it's therefore, you know, peer on peer, and it was delivered by working clinicians. This wasn't a bunch of academics who never look after people with asthma who were on these regional working groups. It was people who have direct day-to-day working experience of asthma and who would be recognised by the rest of the community, the medical community, as being experts in their field. Okay, next slide, please. So enough about how it was done. I think it's worth taking that into account to show the level of intricacy and complexity that was involved in this. What about the findings? And those can be really subdivided into these three headings. So there's a group of stuff that is about the medical and professional care that these unfortunate people received. There's a bit that's about prescribing behaviour and habits and patterns, and the third bit that's about patient factors, which is allied to perception of a risk of poor control, which had come out of the previous regional inquiries in the past. Next slide. So if we look at the medical and professional care ones, some of these are really interesting, and some of them, for me as a GP, are pretty hard hitting. So, number one, personalised action asthma plans were held by, and Mark Levy, when he was interviewed frequently when he presented this stuff in the press, he used to prefix this by saying, by only 23% of those studied. So, anyone that's familiar with the OPC database wants to comment on this now, please.
They don't code their action plans, Ian.
Nobody codes action plans. So how do we know that only 23% of those who died had action plans? Because when the clinicians were asked to describe whether they did or didn't, they would go into the notes and pull out and see if there was a code. That 23% number looks frighteningly familiar to me, because it looks pretty much like some of the numbers that we regularly get off the OPC database, no matter where about in the country you look. So though only 23% of people who died of asthma had action plans, actually the current going rate for having it documented in your notes that you've got an asthma action plan is probably about a quarter, so around about the same number. So no better and no worse than your average asthma population. Now, you can argue whether that's damning or not. You know, maybe people who are at greater risk of dying from asthma ought to have them, but we'll that in a minute when we look at the sort of people who actually die of asthma. Perhaps a bit more worrying is that no review had taken place in 43% of those studied. So our current OPC numbers, I think I'm going to show those in a minute actually. So hold that slide. Yeah, so that's our self-management. If you go back, do you want me to show it? Yep. Thank you. That's the current OPC reviews and self-management hit rate. So these data come from the DLF practices in Staffordshire and the DLF practices in Grampian. So these are, well, Staffordshire is every practice in the area. In Grampian, it's those who are willing to volunteer to have it done. So what you've got there is asthma reviews in the last 12 months, sitting at 50%, 60%, 47%, 35% over the total OPC database, contrasted with 43% in the National Review of Asthma Death. So it's hitting roughly the same spot. If you look at the light blue, that's self-management plans, 26, 4, 17, and does that last one say 19? So you're hitting roughly, you're hitting roughly the same spot with that. Okay, can you go back to slide 14 again, Victoria, please? Thank you. Exacerbation risk factors were documented in half of those studied. In other words, they were documented in the other half. And severe asthma, this was really interesting because what they did was they asked the doctor or nurse, who was the principal identified person looking after this person with asthma, whether they would have described that person's asthma as severe, moderate, or mild. And what you get is, as you would expect, a large number of people had severe asthma. Somewhat surprisingly, an even larger number had moderate asthma, and worryingly, 10% had what their clinicians described as mild asthma. However, if you then went back to look at what those patients were taking in terms of medication, in particular course of rescue medication for exacerbations and frequency of short-acting beta agonist use, and applied the BTS sign guidelines to those criteria, you would not have described many of the people with moderate or mild asthma as having moderate or mild asthma. You would have described them as having significantly uncontrolled asthma. And so I think that reflects on the complacency, and I'll use that word advisedly, but the complacency of the clinicians filling in those forms who thought, well, I thought this person had mild asthma, but actually when you looked at the pattern of their behaviour, their exacerbation rate and their medication use, it almost certainly wasn't mild. And the final bit here is interesting, which is avoidable death if the guidelines are applied, 46%. And if you looked at that, that's basically when this person attended acutely unwell, were they managed according to the BTS sign guidelines. And in 17% of cases, the answer was yes, because although the people knew the guidelines, they didn't apply them. And in 25%, it was people who were first responders to people with acute asthma didn't know what the guidelines said about the acute management of asthma. So that's a real challenge for A&E departments, ambulance services, unscheduled care locations, because people either aren't applying the guidelines, or even although they know them, or they don't even know them to apply in the first place. So that's really challenging. Okay, we can skip to slide 16 now. Thanks. So why did Mark Levy focus on plans, and why have we at OPC focused on action plans? Well, we know from a whole series of Cochrane Review studies now, dating back in adults and children, dating back over the last 10 to 15 years actually, that if you give people action plans together with regular review, together with clinical support, then it has a positive benefit for patients with asthma. And the outcomes for those patients result in better control of asthma and reduced unscheduled care events and reduced admissions to hospital with asthma. Next slide, thanks. And we also know that doctors in the UK and practices in the UK are required by their contract for the last 12 years to review people with asthma on an annual basis. And that when we do that, we should ask at least for some level of asthma control. And unfortunately, there's a huge amount of gaming that goes on with that. And you've just seen that from the OPC statistics, that although many doctors' practices, including my own, which is hiding in that Grampian data, although many doctors' practices will claim full QOF points, actually a substantial percentage or number of patients have been offered 3 appointments, then not taken them up, and are therefore simply exception coded. And exception code rates in practices vary hugely, and sometimes can be, anything up to half of the patients with asthma in the patient population. Okay, next slide. And the whole thing about exacerbation risk factors is really interesting. It's something that we at OPC have been looking at over the last year or 18 months, and we've particularly concentrated on it with regard to the BLF practices. But it's something that's really interesting because if we can't get anything up to half our patients to come in for an annual review, what would be really clever would be for us to be able to work out in which patients of that patient population it's imperative to get them reviewed, and in which patients it's less important because they're doing pretty well anyway. Okay, and the reason for this, the picture of the patient the person painting the wall, is that I think over the last 12 years or so in the NHS and with asthma, we've pretty much concentrated and trying to get a reasonable coat of emulsion across the whole wall in terms of doing the bare minimum for the maximum number of people, rather than concentrating on those who've got the highest risk. Next slide. And I come back to this, that it wasn't just the usual suspects who ended up having acute, life-threatening and ultimately fatal attacks of asthma. There were a group of people who had a more moderate level of asthma. And maybe if a risk scoring system had been applied to those patients, that might have made it more obvious who the ones were who were at risk, because it looks like the doctors and nurses looking after them didn't seem to think that a substantial number of these people were at risk. Next slide. Thanks. And so this comes from the work that's been done with OPC, and this is an OPC slide that you'll recognise. And again, this one comes from the BLF practices in Staffordshire and in Grampian. On the right-hand side is your total database. And what you're looking at here is patients who have got a previous track record of asthma exacerbations. And then if you then add a premium onto that, of looking at patients who are already on higher levels of asthma therapy, step 4 and above, as far as the BTS sign guidelines are concerned, then you end up with knowing who and what size your population are who are at greatest risk. And I have a suspicion, although we haven't applied it in practices yet, but I have a suspicion that if we looked at the 195 people in the confidential inquiry and looked at the 52% or so who were either described as moderate or low risk, then if we applied this risk calculator, I suspect that we would then find a much more accurate way of informing clinical practice as to who is genuinely at higher risk from asthma. Next slide. Thanks. Coming back to this avoidable death, failure to assess in A&E departments and unscheduled care areas, failure to assess the patient accurately was a high issue for the 17%. Unavailability of equipment, unavailability of treatment options, and a failure to apply known guidance. And even more damning, this 25% in which guidance was simply not applied because people were unaware of it. The severity episode was not assessed, treatment not consistent with the level of severity. And in fact, you'll see in a later slide that in fact, in many cases, patients who died of asthma died before they had even accessed any form of medical attention or intervention, which comes full circle back to the whole issue about asthma management plans and asthma action plans. Because if the patients are dying in the community before they've even had a chance to be assessed to see if they've got life-threatening features for asthma, then that means that they are delaying their presentation. Next slide, thanks. So, moving on to medication use, and we've hinted at this already, but we'll expand this now a bit more. Thanks. Slide 23. This is an absolute key finding, and this was the main headline finding that came out of this report. And in fact, Asthma UK did a piece of post-NRAD surveying that they published only 3.5, 4 weeks ago now, where they again hit the same headline and managed to get themselves on breakfast TV and the Daily Mail, etc. Excessive reliever prescribing in 39% of those where medical records could be accessed. 12 or more short-acting beta agonists had been used in the previous 12 months, and in 6 people, 50 beta agonists or more had been used in the previous 12 months. These are people with asthma who are rattling through blue inhalers, reliever inhalers. And something that's come out of David's work for a long time, actually, and right from the very establishment of the OPC database, was that if you match that against underuse of preventer inhalers, or at least under request for prescriptions, then you found that was an absolute key. But also, interestingly, that if you match it with overuse of preventer inhalers, and we've had a hint of that coming through the OPC database for some time, that there are 2 groups of asthma patients who are at risk: those who underuse the preventers and those who overuse them. But the real key is that if you pick those patients out and look at what they're doing with their beta agonists, then you get this clear signal that if you're not doing what you're supposed to with your preventer, and you're not doing what we expect you to do with your reliever, then you are in trouble. And then there's a further small group who Asthma UK again highlighted a month ago, who were getting long-acting beta agonists without inhaled steroids, and who were basically masking the symptoms of their increasingly deteriorating asthma by taking larger doses of long-acting beta agonists with taking a corresponding inhaled steroid. And we've known from work in America over the last decade or so that was a dangerous thing to do. There was a trial done in some inner city populations in the United States called the SMART trial about a decade ago, where they looked at this and they found that people just increased their beta agonist use without taking any form of steroid, and that increased their risk of dying. Okay, next slide. So I put it to you, and I put it to us as OPC, that we could support helping clinicians and practices that are on our database to understand this and to do this. It's a very simple thing to discover which of our patients are taking 12 short-acting beta agonists per year or 6 short-acting beta agonists in the last 6 months. Very simple thing to do. We've done it ourselves just by doing a simple search to identify who these patients are, and lots of practices, particularly practices that come from the Executive of Primary Care Respiratory Society, have done this as well. And in fact, some of them have clubbed together and are going to put an abstract into PCRS conference this coming year as to what the level of unfettered short-acting beta agonist use is in PCRS practices. We already produce data for the practices in terms of as much as we can do in concordance with preventer prescriptions, but there are technical challenges associated with that. We don't actually know how much inhaled steroid goes into the lungs of our patients with asthma, because the problem with that is that there are 3 and potentially 4, but certainly 3 tripwires on the way to knowing that. So we do know what the patient is prescribed. We know what the patient has, or at least pharmacists know what the patients have dispensed. But what we don't know is what the patients have A, attempted to take, and B, successfully taken if they've got good inhaler technique. So anything that we do in terms of data around this as OPC or with my NHS Grampian hat on looking at our pharmacy dispensing data, anything that we do with that is 1 or possibly 2 steps removed from the patients are actually doing. And anybody that's ever worked as a community nurse knows full well that if you open the drawers and kitchens of patients with respiratory disease, you will find dozens sometimes of unused inhalers. So that is a weakness of our data, but it's better than nothing. And most practices actually are operating in a complete vacuum in terms of knowing that. We could quite easily do short-acting beta versus preventer ratio calculation that would support this data and would tell our practices even more accurately where there's a mismatch on both. And we could also take that population, I think, where there's a mismatch, and then pull out whether those patients are or are not exacerbating, whether if that's coded, or we could use oral steroids as a proxy. We could tell the practices which of those patients are on step 4 or step 5, or perhaps even step 3, 4, or 5 of the asthma register. We could also tell the practices where those patients weren't attending for their annual reviews, and therefore end up with a much more stratified risk population, where you can almost imagine, to use kind of George W. Bush or Bill Clinton terminology, if you've got 1 strike, then that's not quite so worrying. If you've got 2 strikes, that's more of a problem. If you've got 3 strikes, then that's a big problem. So if your 3 strikes are that you don't attend, you've got aberrant dispensing or prescription requesting behaviour, and you're exacerbating, then that puts you into the and the 4th strike would be if you're supposed to be on step 4, 5 therapy for your asthma. That puts you into a very high asthma risk group. And then next slide, please, Victoria. Yeah, that one. Another thing that had some interesting conversations about, and in fact we had a conversation the last time I was down at the offices down in Cambridge, is would it be possible for us as OPC with our practices to support practices to get self-management plans even more widely available? So we know from OPC searches, and I've just shown you the data from the BLF practices, how many of those patients have it coded that they have got a self-management plan. Could we apply that knowledge to the practice populations that we are studying, obviously with the practice's consent and cooperation and encouragement? In other words, we could quite easily supply a personalised, to some extent, self-management plan to those patients who don't currently have one, that would say, your name is X, your current medication, we know that because it's is X and Y, and you, and at the moment, you know, you are at risk from your asthma because you've had 2 exacerbations in the last 12 months. Therefore, what you need to do in terms of self-management is know what to do when your asthma gets worse. Now, we could develop, we haven't done this, but we could develop some generic, generalized rules of instruction as to what patients could or couldn't do about their asthma, about changing their asthma therapy if they start getting an exacerbation, or we could have a dialogue with regions or local practices to do that. But it's an interesting thought and concept as to whether a virtually generated management plan is something that OPC could do. Although what we would then have to do with it is then follow that up using OPC data and study whether it was an effective intervention or not. So we know from the work that Dermot did in Leicestershire, in his part of the world, we know that simply furnishing a practice with a practice report results in improved outcomes for asthma. Dermot presented that at PCRS about 2 or 3 years ago. It would be really interesting to see whether furnishing patients with with a self-management plan generated from OPC data would improve asthma outcomes or not. That's an interesting concept that might need some further exploration. Okay, next slide. And then we come to patient factors, and it's really interesting because what you find if you teach asthma all the time, and if you, like me, and if you go around practices and if you go around groups of asthma nurses and GPs and challenge them with this sort of national review of asthma death stuff, the first thing they always say is, yeah, but it's all the patient's fault. And so this is the one that usually generates the most enthusiasm from GPs and practice nurses. Okay, next slide. Thank you. And the patient factors that were derived from the national review were that 65% of patients had contributory factors that we know from the science and from the evidence base increased the risk of dying from their asthma. The most obvious, which is smoking. If you smoke cigarettes, it means that your inhaled steroid inhalers only work about 50% as effectively as they do if you've got asthma and you don't smoke. That doesn't mean that you can just double the amount of it you take. Actually, what you've done is reduced the overall ceiling of effectiveness of your inhaled steroid. So it's only ever going to work about half as well as it would if you were taking the same dose and you didn't smoke. And that's got to be a contributory factor to your risk, because it basically means that you're negating 50% of the potential benefit of the most effective treatment for asthma. Non-attendance for review, talked about from the doctor's side of the desk. It was absolutely clear in this patient group that a large number of them did not attend for an annual review, didn't perceive that there was a need to do so, didn't see that they were getting any value from doing it anyway. And then there was also some stuff about passive smoking in the small number of children whose deaths were studied, and non-adherence is a huge issue for this patient group. And then this really interesting thing that patients lacked perception that their asthma was as bad as it was, and that therefore populates that number of patients who died before they ever sought medical attention. And sadly, that lack of perception also applied to the parents, guardians, and sometimes teachers of children with asthma. And it's a huge number. 70% of cases, it that the poor perception of the risk of that child was facing was a contributory factor in their death. Interestingly, having the asthma diagnosed as an adult is also increases your risk of dying from asthma, and that's something that we could again think of using to inform practices of their highest risk strategy group, because we will know at what age that patient first got a diagnosis of asthma. And something comes out of the guidelines and has come out of the previous regional inquiries as well, that is very clear and well known, is that psychological factors, psychiatric factors sometimes were present, depression, anxiety, drug and alcohol misuse, other existing psychiatric diagnoses, particularly significant psychiatric diagnoses like manic depressive psychosis and schizophrenia. If you've got a significant mental health issue and asthma, you are on a hiding to nothing as far as asthma is concerned. Next, thanks. So having come out with the findings, we'll quickly nip through, because I'm conscious of time, we'll quickly nip through the recommendations. As far as health service organisations, i.e. practices, have a named primary care lead. Review patients who've had 2 courses of oral steroids in the last 12 months. Post-acute review, there's a thought about setting up a national asthma template, which we're currently in discussion with ASK about. Use of electronic prescribed surveillance, I think, is a dead duck in the water unless it's through people like us. An ongoing national audit. There is a rumour of a national asthma audit in England, but they can't quite decide what it is they want to audit, and Scotland are going to wait until England decide before they decide anything. Okay, next slide. Written personalised action plans for all, and we've talked about that. At least annual asthma, structured asthma review, and that's typo, and even more in people with high risk. But this acceptance that if patients won't attend for review, at least what we should be doing is some form of virtual review that allows us to highlight those at greatest risk. Factors that exacerbate asthma, asked about, recorded and discussed, and documented in the asthma plan so that the patients have a fuller and better understanding of them. Asthma control assessed at all reviews, either RCP or using an asthma control test, and healthcare to be aware of the factors that contribute to risk, and increasing this idea that practices will have an at-risk asthma register. Next slide. This is OPC work that you've all seen, and you'll notice the first author and the last actually, and the huge increased risk that getting courses of oral steroids carries. If you have had 1 course, you're 300 times more likely to exacerbate in the next year. 2 courses, 600 times. 3 courses, 2,500 times more likely to exacerbate in the next year. And I think that's something that we ought to be looking at and highlighting at OPC and supporting our practices with. That one key thing significantly increases your risk of having further exacerbations. Next slide. So we've talked about this at length, so this is just a summary really. Review of people who've had 12 or more, including inhaler technique checking, including monitoring those who aren't concording with their inhaled steroids or combinations, and the use of combinations rather than single inhalers at step 3 to negate and prevent the potential for using long-acting bronchodilators in the absence of inhaled steroids. Next slide. In terms of patient factors, the recommendations suggest that these asthma plans should be person-specific. So if there is something like seasonality, if there are medicines that affect their asthma, and these management plans ought to direct people to recognise when they as individuals are ill and what they should do about it. And that might in many cases include patients having their own personally held rescue medication. Smoking is obvious, and a specific education package for the parents and teachers of children who suffer from asthma. And Asthma UK, unfortunately, are going to have to do a U-turn on this one because they had just withdrawn their funding from their school, their very successful school's asthma work, and I think they're going to have to do a U-turn on that. An allergen and smoke exposure limitation, that's particularly relevant in children. Okay, we're coming to the last sort of bits. When this was launched last May, it hit the headlines in every newspaper, and this one here is the Daily Mail, my favourite newspaper, clearly. And next one is what, and you could parallel this for what was said in the House of Commons, actually. The then Public Health Minister, Michael Matheson, said, we will look closely at the key findings of this report and ensure that actions and learning are taken forward at a board level where appropriate. So there is a political imperative, or there was at that time, to say we're going to do something about that. What's happened in the remaining 15 months? Next slide. If you'll pardon my expression, bugger all. The political rhetoric is still strong. Some of the findings have been amalgamated into BTS Sign into good practice descriptors in their most recent iteration of the guidelines that was published at the beginning of this year. Asthma UK is campaigning hard to have this, to have a National Review of Asthma Deaths recommendations as mandatory across the whole of the NHS. And above the Hadrian's Wall, the Scottish Government has requested a State of the Nation review, which the Respiratory National Advisory Group to the Government has now provided for them, and there's been a number of additional questions in the Scottish Parliament about this. So, last couple of slides. What should I do about it? Well, when I teach this, I recommend that practices should not hang around waiting for the government to make a decision or NICE decision or anything else. We should be looking to do simple stuff. And as OPC, I think we ought to consider looking at ways in which we can enhance and support practices through this simple stuff. Next slide. Obvious ones. High sub-users. Frequent flyers to A&E departments, unscheduled care centres, oral steroids I've mentioned. Previous episodes of near death where patients have been in high dependency units or intensive care units, and those who live chaotic lives as a consequence of drugs and alcohol or as a consequence of comorbid psychiatric illness. This patient group are an absolute high-risk group, especially if they're non-attenders. Next slide. And next slide again. And basically what that requires is good clinical leadership within the practice. That's getting into good habits of regularly updating their own staff, of doing significant event analysis every time that there's a near-miss asthma death, or tragically and hopefully avoidably every time there is an asthma death. Asthma exacerbations should be documented. Personalised asthma plans should be documented and coded. And there are a number of practice improvement tools that Primary Care Respiratory Society has developed to support this process. And I'm just in the final phases, actually. It's currently out with, next slide please, it's out with the editors in terms of a practice improvement tool. We already have a post-acute asthma care bundle improvement tool, and we're currently at the final editorial stage of having a RU-NRAD ready improvement tool where practices can contrast what they're currently doing against the primary care recommendations that have come out of NRAD. And I think that we as OPC in those practices who are on our database could support that process. You can skip that one actually. And you can skip that one because that's all just duplicates of what I've already said. So for more information on all this stuff, the review itself is a big read. I mean, it's hundreds and hundreds of pages, and I wouldn't recommend that anybody from OPC read the whole thing. But the recommendations, particularly the primary care recommendations, is a nice bit at the back, which Mike Thomas was the principal author on, and is worth having a look at. And you can get that online at the Royal College of Physicians website. And there's a nice little précis of it in the primary care respiratory update, which you can get a hold of through the Primary Care Respiratory Society website as well. And that's pretty much all I've got to say on the topic, so I'm open to questions and discussion.
Thanks, Ian. I've got one question to start off. Just listening to you go through that, obviously one of the things that came up was the lack of asthma reviews that had occurred with these patients who had died due to asthma. And I think, obviously, working with OPC, it's clear that a lot of practices are working towards QOF, and therefore really looking to, if patients don't answer for their asthma review, then they basically want to try and exempt them from it as soon as possible so they still get paid.
Yes.
In terms of those patients, I think you touched on it briefly. Is there not a need for those patients who, just through regular contact, you can't get hold of, that a virtual review is done via the medical records?
Yes.
To just look at sort of use of SABA inhalers, these things that have come out, and then to inform the patients that they are actually at risk, because it seems that they don't actually know they're at risk either.
Yes, and yes. So there is nothing preventing a practice from doing a virtual review in a patient who has had 3 invitations and who has not attended, because contractually, if a patient has 3 invitations and doesn't attend, I am legally and contractually allowed to exempt them until next year, which means that I get my QOF points from them. And the problem is that most practices then say, right, that's it, we don't need to do anything with these patients. If those practices who are conscientious and who are interested and who want to do a better job can then go and do this virtual review, either doing searches themselves, just sitting down with the case notes and going through them, or if we were supporting them, we could give them data and information that told them who their high-risk patients were according to all the stuff that I've just discussed. So, aren't taking the preventers, rattling through relievers, having exacerbations, getting course of oral steroid, haven't had their inhaler technique checked for I don't know how long, and they've got substantial comorbidity that's also quoted within the notes. We could provide us a population of those patients in whom, so rather than saying to them, please do a virtual review on everybody, we could make the job simpler by saying, if you did a virtual review on this population, then that would be the most effective and efficient way of identifying those patients in whom you've got the greatest risk. But the biggest barrier to that in practice at the moment is just busyness. People are too busy, doing all the other stuff that QOF requires of them for all the other diseases that QOF. I mean, we've done sessions on QOF and what a cumbersome and difficult process it is for practices. But something that would make that easier for practices would perhaps increase the chances of hitting this particular population. And the other thing that goes with the virtual review are 2 more things, which is, right, now that you've done that, what are you going to do about it? And yes, so you asked, the supplementary to your question was, how could we then help to inform the patients? And that's really interesting, because what some of the London group have done recently on a side issue is they've started to send out to patients who are on high-dose inhaled steroid a card that says, you are at risk from the high dose of your inhaled steroid that you're on. And what they've presented data on this, where what that then did was empower the patients to go back to the practice and say, I don't think I need to be on this higher dose of inhaled steroid. Now, the parallel there is obvious, that if we were to inform patients directly, with the practice's consent obviously, that they are at higher risk from their asthma, what might that mean as far as the patients are concerned? Would that prompt a change in behaviour from those patients? Because what NRAD tells us is that those patients don't perceive that they're at high risk from their asthma.
Yeah, that's what I was thinking. And I suppose if you do inform a patient that they're at risk, I would say, certainly for a group of them, I'm sure there'll be some who just still don't listen, a group of them will then take this more seriously when they are invited for a review.
Yes, and the Northwest group, jumping into COPD, the Northwest group did this with COPD. They directly sent out to patients with COPD what they called the patient passport, which was sort of 7 things that ought to happen if they had COPD. And what it prompted was it empowered the patients to go back into the practice and say, actually, I've got this thing from the Northwest respiratory people that says I should have X, Y, and Z, and I don't. So can I have those, please? Now, there is an inherent risk in that you piss practice off. And as OPC, we don't necessarily want practices to then vote with their feet and leave us. But if we did it with their approval and consent and encouragement, then I think it might well empower patients. And the final thing that we can do, which we've done as a practice, is to at the very least then say to the person at the front desk, there is a patient population out there who are at greater risk from their asthma, and if they present, they should be fast-tracked.
Yeah.
And so what we've done with that patient group is we've written what we call anticipated care plans for them, so that embedded within their record is a document which alerts out-of-hours ambulance services and A&E services and says, we know this patient is at high risk from their asthma, please take them seriously, because they probably won't. It doesn't say that, but it says this patient has been identified as being at high risk from their asthma. So there's three things that we could support there. Supporting people to do virtual reviews targeted. Second is telling the patients that are at higher risk. And third is telling the NHS that these patients are at high risk.
Hello?
Has anybody else got questions? Yes, please.
Yeah, I was just wondering if you'd seen or if other people had seen the Realise data from the Realise study, which shows really interestingly that patients are overestimating how controlled their asthma is. And if you go and look at some of the data, you often have patients sort of saying things like, "Oh no, my asthma's fine. I only take 3 blue inhaler puffs every day," and they'll really, really underestimate just how serious or how badly managed their own asthma is. Absolutely,
that's been a consistent signal from lots of data over a long period of time. I mean, John Hockney did a thing, Living and Breathing, probably about 2002, I'm guessing, would be the publication date for that. And what he did was he asked patients what the level of their asthma control was, and asked patients to, put it on a linear analog scale, 0 to 10. They then showed them the BTS sign guidelines that described what good control of asthma was, and asked them to rescore themselves. And when they rescored, their linear analogs doubled in terms of the loss of control.
Yeah.
So
no, I know that.
Yeah, and the problem is that if you've got guideline controlled asthma, it means that you're using less than 2 beta agonist inhalers a year. In fact, you're probably using less than 1 beta agonist inhaler during a year. And there's this cultural norm in the United Kingdom that using half a dozen in a year is no big deal.
Yeah. Yeah.
But what Mark Levy and his group tells us is that once you get over that kind of, they did kind of pick an arbitrary number at 12 per year, but it was based on a reasonable calculation of the stats and numbers. If you are over 12 per year, then you're at a tipping point in terms of your risk of death or near death from your asthma.
Just one more question here for me. Do you think there'll be another asthma review of deaths?
Well, that's a good question, Victoria. I would be surprised if in the foreseeable future anybody manages to commission the government to do another one. What depresses me a little bit is my last 2 or 3 slides, the lack of direct action from those people who have the power to make this change, which has to be central government, basically. That's central government in Westminster or Holyrood or wherever. I have this suspicion that the publications that I showed you at the very start from 1990 and 2005, 6, if we did another inquiry in 10 years' time, we will probably find that exactly the same truths prevail. And those truths really are about behaviour. They're about the behaviour of clinicians who are too busy to do this properly because there are too many people with asthma. And they're about the behaviour of patients who, the last question highlights, which is that patients themselves don't perceive the risk that they carry from their asthma. And the problem is that if there are 5 million people in the country who have asthma, and if the worst estimates are that 1,500 of them die a year, then do the maths yourself. It's a small risk, and most practices will go number of years before they will see somebody who dies of asthma. But each time it happens, it's a tragedy, and it's more often than not an avoidable tragedy.
Do you mind if I quickly ask a question?
Yes, please do.
Yeah. I think it might be more aimed at Victoria than you, Ian, but we've got a new risk tool coming down the road for OPC tools, if I'm not mistaken. Have we sort of taken this into account with how we've designed it?
Yeah, the risk tool that you're talking about, Adam, I believe is the one which Ian mentioned up here, this one.
I was about to say, he pretty much outlined a risk tool. I thought,
yes,
that'd be quite useful to compare against, but if that's pretty much what
that is the risk tool that we're going to implement. So it's, Ian, you were, I think, involved in this a while back, implementing this in our service.
Yeah, so that gives you your asthma risk prediction, but the bits that I as an interested clinician could overlay on the top of that are the patient behavioural bits. So if you take the clinical, we know that if these things happen, then you're at greater risk, and you then filter that through a behavioural model of, and we also know that patients who behave in this way are at greater risk as well, then you concentrate that risk to an even greater degree. And so if I'm looking for my, to use that oft used analogy, my hanging fruit, then I'm going to apply both of those. I'm going to use the clinical risk tool, and I'm going to apply the behavioural risk tool and come up and pull out my top 20 that I need to hit hard and hit soon, if you like.
Okay, fair enough. The next one was, you were talking about giving self-management plans to patients we can't get into clinics, essentially, for the asthma reviews. With the way OPC Tools is going, hopefully with that sort of N3 stuff, we could, in theory, post them the management plan we come up with through OPC Tools when we send them out a questionnaire, couldn't we?
It's almost as if he's spoken to me, but he hasn't, Ian.
Yeah, we could do that. I mean, this one, I mean, I mentioned it as we went along, and I mentioned all the potential positives from this. There is a risk in this, and the risk is that what we are potentially talking about doing is a non-evidence-based intervention, because the Cochrane reviews that I showed you a slide of, the Gibson Cochrane reviews in adults and children, all of them conclude that self-management together with regular review has a positive benefit in terms of reducing adverse outcomes in asthma. And what we're talking about here is going one step beyond that and providing personalized self-management information specifically, actually, that patient population that don't turn up for review.
Yep.
Okay?
Don't we also run into sort of issues with information governance if we're directly giving the patients feedback from their own reviews?
That's a jolly good question. Which
not if it comes from the practice. Not if it comes from their GP.
But it would have to go through the practice.
It would go through the practice.
Yeah.
So what we would offer in my mind, what we offer to the practice is we would say to the practice, as part and parcel of OPC, one of the things that we're going to be doing is providing you with the questionnaire-based data that augments the read code-based data that goes into your report. If you want, we can also augment that further by providing personalized self-management plans for your patient population with asthma that you find it difficult to give self-management plans to. Okay? Now, if we do it that way, that should get over all the governance hurdles. What it still doesn't get over is whether that's an evidence-based thing to do. And the problem with that is that we need to think that one through, because actually it would only become an evidence-based thing to do if we then provided the evidence.
Yeah, exactly. I think you'd have to pilot it, wouldn't you, in an area and see if it.
Yes.
And I think it has potential to be quite effective. At least it would raise awareness that they're at risk.
And so the sorts of outcomes that I'd be looking for from doing a pilot like that would be hard outcomes like reduced exacerbations, reduced courses of oral steroid used. But I would also look for another outcome, which would be increased uptake of asthma reviews. If we send out self-management information to people, and the first thing they do with it is to say, I don't understand all this, I better go and see the nurse about it, then that's a positive outcome. Yep.
That's very true.
Yeah. So I think it would be interesting. I think there's I think there are two ivory tower white elephants, to mix my metaphors, which exist within respiratory, and one is this whole thing that you can't do asthma self-management without it being personalised and also supported by individual patient review. I actually think that self-management plans in themselves have value, whether the patients sat down with their nurse or doctor or not. And the other one is it's all singing, all dancing pulmonary rehabilitation, as opposed to a decent exercise class over a decent length of time. And I think that they're both being built up by people who have got empires to build. And it would be actually quite nice to deconstruct the self-management. that's just me being
distracted.
Iconoclast, I suppose. Yeah.
Interesting. Any other questions from anybody?
The only other thing I was going to mention was you were talking about doing virtual reviews on patients you couldn't get hold of.
Yeah.
Practices can essentially just use OPC tools to run at least the starting point for that. Is that something we should be using when we're marketing it? Sort of saying, and if you get to this point and we still can't get them in, this is a useful tool to have.
I would love for us to be doing that because for the last how many years, what we've done in Peterhead is to invent ways of providing ourselves with information that OPC already provides us with, or now already provides us with. And so we've gone the long way around in doing this and developing searches and all sorts of different ways for our nurses to understand what's going on with the patients. And actually OPC is now in a position to provide that information very, very easily and readily. And the way that we do it in practical terms is that we recognised a number of years ago that patients who've had, and NRAD tells us this as well, patients who've had an exacerbation of asthma should be reviewed within 72 working hours of coming home, whether they've ended up in the hospital or whether they've been at an A&E department. And so we set aside in our practice a finite number of appointments every week for those patients who've had exacerbations. And if those exacerbation appointments aren't then filled by patients who either choose not to come or there haven't been that many exacerbations that week, that then loosens up nursing time to do virtual reviews in our highest risk patients. So their time is used in a constructive and useful way, whether the patient who's had the exacerbation comes or not. And most practices don't build that into their system, but we built it in years ago, and so we've been able to do these virtual reviews but we've not done it using OPC tools. We've done it using a bunch of searches that we made up for ourselves.
It would be useful, I think that definitely, Adam, we should be raising awareness that we can support practices with this. Ian, it would be useful to have Peterhead as an example of a practice who does this, maybe not using OPC tools previously, but a practice which has used these tools to sort of support them in bringing in their risk patients.
Absolutely fine.
Yeah?
Yep.
Okay.
Yes.
Good.
Because our exception code rate is just as high as anybody else's. Our population is in fact, our population in many ways is more mobile. Peterhead has now become a commuter town. And so the idea that you would go for your review at 2:30 on a Thursday afternoon, for most of our working population with asthma is just frankly daft, because most of them are 35 miles away at their jobs in Aberdeen at 2:30 on a Thursday afternoon. So we find it extremely difficult to get our patients in for their asthma reviews. I go on record as having been a persistent asthma review defaulter myself for the last 2 or 3 years. I've actually corrected that now. I went for my own asthma review about 2 months ago, just to get it off the system. But it is a genuine challenge for practices, and not that practices are being lazy or cynical. Many times it's really difficult to get people to come in because they're busy folk,
But they don't mind getting something in the post.
No, they don't mind getting something in the post. No, I think it'd be good.
Interesting.
Okay.
Brilliant. So thanks a lot. I don't think there's any other questions unless somebody wants to butt in. So thank you, Ian, for your time today. It's been very useful.
Thank you.
Thanks so much.
Yes, and we'll see you.